Hello, Andrew Wolf here. In this video I'm going to talk about some of the determinants of cardiac output. And we talked about this formula before where we have cardiac output is equal to stroke volume times heart rate. Now I'm going to break this down a little bit and we'll talk about, well, I want to talk first about sort of determinants of stroke volume. So we'll break this down into sort of a separate category here. Now stroke volume is equal to the total ventricular volume at end diastole minus the residual volume. Okay, so that's here just to illustrate that. If we have a left ventricle here, the stroke volume is going to be equal to the amount that's ejected from the ventricle, and that product is going to be equal to the amount that fills the ventricle minus the amount that's remaining after ventricular contraction. Okay, so that's the residual volume, this is the total volume, and this here is the stroke volume that actually gets ejected from the ventricle. So you can see there's two very simple ways of increasing stroke volume. You can increase ventricular volume, or you can decrease residual volume, right? Decreasing residual volume is equivalent to increasing ejection fraction, right? So that's the percentage of blood that is ejected out of the total volume. Okay, so let's talk about factors that increase ventricular volume. So what would increase ventricular volume? Well, the primary way of increasing ventricular volume is increasing the amount of blood that's returning to the heart. So if we increase the amount of blood that's returning to the heart, we're going to fill the ventricles much more quickly. So what can increase the amount of blood returning to the heart? Well, this brings us to a new equation called Darcy's equation. Now, Darcy's equation, you don't need to have these equations memorized, I really just want you to understand the concept. Darcy's equation looks like this. It is flow equals pressure divided by resistance. Now in the body, of course, this is going to be blood pressure, and this is going to be peripheral artery resistance. And blood and flow is going to equal cardiac output. So Darcy's law for physiological purposes essentially means that, well, here I shouldn't say cardiac output. In the end it will increase cardiac output, but right now we're talking about flow back to the ventricle, so we're actually talking about ventricular volume. Equals blood pressure divided by vascular or peripheral resistance. Okay, so the body actually does a very good job of maintaining a constant blood pressure, and it does this by, we sort of have automatic responses that if blood pressure decreases, we increase heart rate or contractility, and we'll get into that a little bit. So peripheral resistance, interestingly enough, there are some central controls for peripheral resistance, but the main determinant of peripheral resistance is actually the amount of oxygen that is needed in the tissues. Now, hypoxia is a very potent vasodilator. So if we have tissues, let's give an example where we have a person that is starting to run and is using their muscles. And these muscles quickly use up the oxygen available to them and become hypoxic. Now the low level of oxygen in the intracellular fluid is going to trigger smooth muscles in the arterioles to dilate. And we're going to end up with dilated arterioles. And there's some other factors in here too. Hypoxia is a very potent vasodilator, but also, so we have vasodilation. It can be caused by hypoxia, increased hydrogen ions, so in other words, decreased pH. And there's some other mediators as well. So if we have muscles that are crying out for oxygen, we have them all over the body, we're going to end up with vasodilation, and this is going to decrease peripheral vascular resistance. So by decreasing resistance in muscles all over the body, we're going to increase flow back to the heart. So that is going to increase ventricular volume. So one of the main factors in controlling cardiac output is actually tissue perfusion, which is controlled by local tissue needs for oxygen. Okay, so that's one component. Now there's also other components that increase ventricular volume. One is we have in our venous system, particularly in our inferior vena cava and other large veins in the body, these veins are surrounded also by smooth muscle, and these smooth muscles are inspired to contract by information from the sympathetic nervous system. And the sympathetic nervous system triggers these to contract in response to hypoxia and low pH. And it may also do it in response to a fight or flight response, right? Stress. So squeezing the inferior vena cava and other veins in the body will also increase ventricular volume, blood flow back to the heart. Okay, so that's ventricular volume. Now let's talk about decreasing residual volume, which is akin to increasing ejection fraction. How do we do that? Well, we do that by increasing the contractility of the ventricles. Now this happens naturally. There's two ways that this happens. One is through a process called the Frankstarling Curve. And another is through positive inotropic agents. Yeah, I'll talk. The inotropic is sort of the easiest one to understand, because what is the major inotropic agent in the body? Positive adrenergic activity. So sympathetic nervous system again. And again, this could be due to hypoxia, acidosis, or a fight or flight response. Okay. Now, the other thing that can increase the contractility of the heart is the Frankstarling curve. Now, this is interesting because it actually is very closely related to ventricular volume. When we have increased ventricular volume, the physiology of our heart is such that the ventricular volume, increased ventricular volume itself up to a point, will actually increase the force of contraction of the ventricle. Okay, so let's talk about the Frankstarling curve. So basically, what we have here is we have end diastolic volume, which is going to be what I've been calling ventricular volume. So this is the maximally filled ventricle. And we have here the stroke volume, or the amount that's ejected from the ventricles on systole. And with the Frankstarling curve, as end diastolic increases, the stroke volume increases as well. Actually, and part of this is due just to the increased volume, and part of this is due to increased ejection fraction. Now, why does ejection fraction increase when there is an increase in end diastolic volume? Well, if you look at the ventricles, as the ventricle fills, if you increase the amount that it fills, the ventricle is going to stretch. And when the ventricle gets bigger, the muscle fibers themselves stretch. So we have the muscle fibers getting longer. And if you look inside at the muscle fibers, what you have is you have actin fibers here in blue, and then in between each of the actin fibers you have some myosin fibers here. And we have here at the top a stretched out fiber. And what you can see with this, what this is illustrating, is that when you have a stretched out fiber, the actin and myosin are ideally stretched apart to the point where there is actin and that the actin and myosin can bind very easily. Now here we have a shortened fiber because we have an underfilled ventricle, and with the shortened fiber, the actin and myosin are not well matched because the actin fibers are too close together, and the myosin fibers don't have quite as many binding sites. So this one is just right, just the right amount of stretch. And to a point, the more you stretch the fiber, the more efficiently it's going to contract because you're aligning the actin and myosin just perfectly. When you're too short, you have a weaker contraction. Now, if you're too long, if you're overstretched, you're going to end up with a problem as well, because you're going to end up again where the actin and myosin are not ideally bound to each other. So the Frankstarling curve works up to a point and then it starts to drop off again. So when you increase volume too much, then the ejection fraction actually starts to go down again, and that's because you end up with a situation like this where the actin and myosin aren't even reaching each other. Okay, so generally the more the heart stretches, the stronger the contraction, because these muscle fibers are perfectly aligned, and when they're too short they're not well aligned. But if they overstretch, the ejection fraction starts to go down again. Okay, so that brings us, sort of discusses the factors that affect residual volume: the stretch and increased inotropic activity. Okay, so we've discussed stroke volume. Heart rate is relatively easy. Heart rate is primarily controlled by the sympathetic nervous system. So the same thing, the same system that is increasing contractility and increasing blood flow to the muscles. Now, There's basically two parts of the autonomic nervous system that control heart rate. So we're going to talk about regulation of rate. All right, we've got on one side the sympathetic nervous system, or I should say adrenergic, because it's not just the sympathetic nervous system, it's also the adrenal medulla, so norepinephrine and epinephrine. Wherever it is excreted from, whether it's excreted as a neurotransmitter from nerve endings that are connected to the heart tissue, or whether it's excreted by the adrenal medulla, the heart receptors pick it up in the same way and have the same effects. Now remember, we talked about this before. What are the three effects that the sympathetic nervous system has on the heart? Well, we have increased inotropic response, which is force of contraction. We have the dromotropic response, which is the speed of conduction, primarily through the AV node, and then increase chronotropic response, which is mainly what we are discussing here. So we increase heart rate. Now, these three effects together can increase cardiac output by 4 to 5 times, so a factor of 4 to 5, especially when they are coupled with arteriolar responses. Okay, and then on the other side here we have the parasympathetic nervous system. Now the parasympathetic system, actually, I should probably talk about the chronotropic response here. So the chronotropic response is due to the influence of the heart on the SA node. And what does it do with the SA node? It increases the leakiness of, here, this is a action potential, and if you remember my discussion about action potentials of cardiac cells, what happens, what the sympathetic nervous system does is it triggers the, it causes the leakiness of the pacemaker cells to increase. So that increases the pace. Well, I didn't draw a very good action potential there, but it increases the pace at which the cardiac cells will induce an action potential. Okay, so we end up with a steeper curve here in the middle of our action potential because the sodium is leaking in quicker. And that's how it works. Parasympathetic system does the exact opposite. It flattens out the curve. So it takes longer for the pacemaker cells to reach threshold and start an action potential. Okay, so that's parasympathetic, and really the parasympathetic only has that effect. However, the parasympathetic effect can be quite dramatic. It's really only a one-trick pony. It only can decrease heart rate because of its effects on the SA node via the SA node pacemaker cells. But it can be very potent. It can actually stop the heart rate completely. It can completely block SA node function for up to 20 seconds. Actually, it just stops it totally. It just stops SA node pacemaker cells completely. But after about 20 seconds, other pacemaker cells will kick in. So you'll end up with a ventricular escape rhythm. So what you'll end up with a patient that has a very strong parasympathetic outflow, you'll end up with an EKG that looks like this. We get a normal heartbeat, and then you'll end up with a 20-second pause, and then you'll end up with a very slow rhythm until the parasympathetic system stops doing what stops its activity and restores normal heart rate. So when does this happen? Well, when we have a strong vagal stimulus, and we end up with what's called a vasovagal response. That's due to stimulus of the vagus nerve that reflexively stimulates a strong parasympathetic outflow, and then you end up with stopping the SA node pacemaker, and all SA node pacemaker activity stops. You end up with a 20-second pause, and then the patient begins to recover with a ventricular escape beat or a junctional rhythm or something else that's not coming from the SA node. So you end up with a patient that passes out. And then the backup rhythms take over, and the patient usually will begin to recover after about 20 or 30 seconds. Okay, so that's my discussion about the regulation of flow from the heart, or the determinants of cardiac output. Please take a moment to provide feedback, and if you want quick and easy access to my other pathophysiology videos, please click on this link here to find your way to my channel. Thank you very much.